Somewhere between two rheumatologists, one blood test, and a normal MRI, there is a version of you that nobody has fully explained. You have Sjogren disease. But your worst days do not look like dry eyes and dry mouth. They look like burning feet at 2 a.m., joints that will not calm down no matter what medication you try, a brain that loses words mid-sentence, a heart that races when you simply stand up from a chair, and a throat that suddenly feels too tight to swallow a piece of bread. You have probably sat across from more than one specialist, describing the same tired body in slightly different words each time, hoping someone would connect the dots you already sense are connected. Somebody probably told you this is just aging. Somebody may have said it is anxiety, or menopause, or fibromyalgia, or stress. And you have quietly wondered whether something important has been missed, whether the reason nothing quite fits is that you're being asked to describe two diseases as if they were only one. This feeling has a name, even if no one has said it to you directly. It's the experience of living inside a condition that keeps getting split into pieces by the very system meant to understand it. One doctor manages your eyes and mouth. Another manages your joints. A third manages your mood, or your sleep, or your gut. Each of them may be doing careful, competent work. But if none of them is looking at the space between their specialties, the most important pattern in your body can go unnamed for years. Here is what almost nobody tells you plainly. Most people with Sjogren disease do not have Sjogren disease alone. Recent patient survey data found that about 2 out of 3 people with Sjogren also carry at least one more autoimmune diagnosis. Lupus, rheumatoid arthritis, scleroderma, thyroid disease. And when two autoimmune diseases share the same body, they do not simply add their symptoms together. They create a third pattern. A pattern that is often worse, harder to treat, and slower to diagnose than either disease would be on its own. In the next several minutes, you will learn 3 specific things. First, the one symptom inside each major Sjogren overlap that research shows is measurably worse, more resistant to treatment, or more often missed than doctors expect. Second, why a normal nerve test or a normal blood panel does not mean your nervous system is fine, and what the research actually shows about that gap. Third, a way to describe your symptoms to a doctor that focuses on patterns and timing, so the connections are harder to dismiss. Around a third of the way through, we are going to look at a nerve finding that explains why burning feet, dizziness, and brain fog can all trace back to the same small fiber problem, a connection that rarely gets explained to patients in plain language. This video is meant to help you recognize patterns and prepare better questions for your medical team. It is not meant to diagnose you, and it will not replace your doctor. Let's start with the overlap most people have never heard framed this way: Sjogren disease combined with lupus. Picture this. You wake up and your joints ache in a way that feels different from yesterday. Your skin flares in a strange, blotchy pattern after 10 minutes outside, in a way it never did before. You are more tired than the day before, even though you slept the same number of hours, and the fatigue feels heavier, almost like wading through water. If you only had Sjogren, doctors might expect dryness, fatigue, and mild joint aches. If you only had lupus, they might expect joint pain, skin sensitivity, and organ inflammation. But when both diseases are present together, researchers in a 2024 study from 2 Italian rheumatology centers argued that this combination behaves like its own distinct condition, not simply lupus with extra dryness bolted on. The overlap group showed its own clinical fingerprint, separate from classic lupus alone or classic Sjogren alone, meaning the two diseases together shift the symptom pattern rather than simply stacking 2 separate lists on top of each other. Why does this matter to you? Because if your doctor is only screening for one disease at a time, checking Sjogren symptoms in one visit and lupus symptoms in another, the interaction between the two may never get named. Sun sensitivity that flares fast, joint pain that moves between different joints instead of staying put, and unusual fatigue that spikes for no clear reason are exactly the kind of clues that suggest the overlap pattern rather than either disease in isolation. The medically responsible action here is not to self-diagnose lupus. It is to track when skin flares happen in relation to sun exposure, note whether joint pain moves or stays in one place, and bring that timeline to your rheumatologist as a specific question. Could this represent a lupus-Sjogren overlap pattern rather than 2 separate coincidences? That single question can redirect an entire workup, because it tells your doctor you're not just reporting symptoms, you're reporting a pattern. Consider a composite example, built from commonly reported experiences rather than any single real patient. A woman in her 50s is diagnosed with Sjogren after years of dry eyes. 2 years later she notices a faint rash across her cheeks after a weekend outdoors, along with new swelling in her knees that seems to move to her wrists a week later. Her Sjogren labs look stable, so the rash and moving joint pain get treated as separate, minor issues at first. It's only when she brings a written timeline connecting the sun exposure, the rash, and the joint movement to one visit that her care team considers testing for lupus overlap specifically. This kind of scenario illustrates why timing and clustering, written down in advance, can matter more than any single symptom mentioned in isolation. But sun-sensitive skin and moving joint pain is only one overlap. There's a second one that shows up in a much more common combination, and it explains why so many Sjogren patients feel like their joint disease is winning even on treatment. Sjogren disease overlapping with rheumatoid arthritis is one of the most frequent combinations there is. Research using a large United States patient registry found that roughly 3 out of 10 people with rheumatoid arthritis also meet criteria for Sjogren disease, and that number climbs the longer someone has lived with RA, rising from around 1 in 7 in the first year of RA to nearly 4 in 10 after a decade. Picture what this feels like in daily life. You are on a treatment plan for rheumatoid arthritis. Your rheumatologist adjusts your medication. Your labs improve a little. But your joints still feel swollen, mornings are still stiff for hours, buttoning a shirt takes longer than it should, and you still feel like the treatment isn't quite working the way it's supposed to. Here is what a real-world cohort study found, and it deserves to be said clearly. Patients with both Sjogren and rheumatoid arthritis were significantly less likely to reach remission compared with rheumatoid arthritis patients who did not have Sjogren, even after researchers accounted for age and other differences between patients. Depending on which disease activity measurement was used, the probability of reaching low disease activity or remission dropped by somewhere between about a fifth and a third. That is not a small statistical footnote. That is the difference between feeling like your treatment failed you and understanding that a second disease is quietly working against the first one's treatment response. This is supported evidence, not speculation, but it does not mean your specific case will follow the same path, and it does not mean you should change medication on your own. What it does mean is that if you have rheumatoid arthritis and you are not reaching the improvement your doctor expects, dry eyes, dry mouth, or unusual fatigue are worth mentioning specifically, even if they feel like a separate, smaller complaint. Ask directly whether Sjogren-specific antibody testing or a minor salivary gland evaluation makes sense given your treatment plateau. That is a focused, reasonable question, not an accusation that your doctor missed something. Part of why this plateau is so easy to misread is that the two diseases can share the same visible battlefield, your joints, while running on different underlying engines. Rheumatoid arthritis activity is often tracked using inflammation markers and swollen joint counts. But fatigue, widespread achiness, and a sense that your body simply isn't recovering between flares can be driven partly by the Sjogren side of the equation, which standard RA scoring tools were never designed to capture. That's not a flaw in your doctor's approach. It's a gap in what the tools were built to measure in the first place, and naming that gap out loud is often the first step toward closing it. Now here is where the pattern shifts, because the next overlap does not primarily show up in your joints or your skin. It shows up in your lungs and your throat, and it's one of the more serious findings we'll cover today. When Sjogren disease overlaps with Scleroderma, researchers have found that Sjogren shows up as one of the most common co-occurring autoimmune diseases in Scleroderma cohorts, alongside thyroid disease. And the overlap doesn't stay quiet in the background. Multiple studies point toward higher rates of interstitial lung disease, a form of lung scarring, in people with overlapping connective tissue diseases compared to a single disease alone. Picture what that feels like day to day. You notice you're more short of breath walking up the same stairs you've climbed for years. You assume it's fatigue, or being out of shape, or simply getting older. But shortness of breath that is new, that worsens over weeks, or that shows up with a dry cough deserves a specific kind of attention when Scleroderma and Sjogren occur together, because interstitial lung disease is one of the more serious complications tied to this overlap and it responds better to early treatment than late treatment. There's a second part of this overlap that almost never gets mentioned, and it happens at the dinner table instead of in a lung scan. Scleroderma is already known for weakening the muscles of the esophagus, the tube that carries food to your stomach, causing slow, sluggish swallowing and reflux. Sjogren adds its own separate mechanism on top of that. Reduced saliva makes it physically harder to move food down, and some research has found that Sjogren disease can involve autoantibodies affecting the nerve network inside the esophagus itself, along with impaired parasympathetic nerve function, contributing to abnormal esophageal motility in a notable share of patients even without scleroderma in the picture. Studies measuring esophageal function directly have found measurable motility abnormalities in somewhere between roughly a third and two-thirds of Sjogren patients tested, and patient-reported swallowing difficulty in about 6 out of 10. Picture what that feels like. You start taking smaller bites without really deciding to. You keep a glass of water at every meal, not out of habit, but out of necessity. Bread, crackers, and dry chicken start to feel like a small daily obstacle course. When Scleroderma's muscle-based swallowing problem and Sjogren's saliva-based and nerve-based swallowing problem occur in the same person, the two mechanisms compound rather than cancel out, which may explain why swallowing difficulty is often reported as more severe in this specific overlap. To be clear about what the evidence supports and what it doesn't, research does show connective tissue disease overlaps carry meaningfully higher lung involvement risk, and separately, esophageal motility studies do show measurable dysfunction in a substantial share of Sjogren patients, sometimes independent of dry mouth severity. What the evidence does not support is diagnosing yourself with lung disease or a swallowing disorder from a video. If you notice new or worsening breathlessness, a persistent dry cough, reduced exercise tolerance, or a swallowing pattern that has changed, such as needing liquids with every bite or food catching in your throat, and you carry a Sjogren or Scleroderma diagnosis, that is a conversation to have with your doctor about pulmonary function testing or a swallowing evaluation, not something to wait out. And if you ever experience sudden severe difficulty breathing, choking that does not resolve, chest pain, or fainting, that is not something to schedule for later. That requires emergency care immediately. That single distinction, between worth a scheduled conversation and requires urgent care now, is one you'll want to keep in mind, because it comes back again in the next section. Let's talk about the overlap almost every Sjogren patient has lived through without a name for it. The connection between nerve symptoms, dizziness, and the label "it's probably nothing." Recognize this moment. You stand up from the couch and the room tilts for a second. Your feet burn at night even though nothing touched them, and pulling a blanket over them makes it somehow worse. Your hands feel colder than they should, or you notice you're sweating unevenly, more on one side of your body than the other. Driving at night feels harder because your feet don't quite register the pedals the way they used to. You mention this to a doctor, they check your reflexes, they may order a standard nerve conduction study, and it comes back normal. You are told this is probably stress, or restless legs, or simply nothing serious. This is one of the most underexplained gaps in Sjogren care, and the research on it is more specific than most patients ever hear. Here is the mechanism, in plain language. Sjogren disease can damage very small nerve fibers, the ones responsible for pain, temperature, and automatic body functions like heart rate and sweating. This is called small fiber neuropathy. Standard nerve conduction studies are built to detect large nerve fiber damage. They are not designed to catch small fiber damage, which is why they can look completely normal even when small fiber neuropathy is present. Research on Sjogren-related small fiber neuropathy found that skin biopsies, a small sample of skin examined under a microscope, detected reduced or abnormal nerve fiber density even in patients whose standard nerve conduction studies were normal. In other words, a normal nerve test does not rule this out. There's a second detail that matters just as much. In classic small fiber neuropathy, damage usually follows a length-dependent pattern, starting in the feet and moving upward, the longest nerves affected first. But research on Sjogren-associated small fiber neuropathy found the damage is frequently non-length dependent, meaning it doesn't follow that expected order, which is one reason it can look confusing on a standard exam. That mismatch is part of why it gets missed or misattributed. And here is the finding that connects burning feet to dizziness. One study found that small fiber neuropathy in Sjogren was strongly linked to dysautonomia, autonomic nervous system dysfunction, with roughly an 8-fold higher likelihood of autonomic symptoms in patients with small fiber involvement compared to those with large fiber nerve damage alone. Vasomotor symptoms, meaning changes in blood vessel behavior that can cause dizziness or flushing, showed up in about 2/3 of one small fiber neuropathy group, and uneven sweating in nearly half. In a separate case series, burning pain was reported by roughly 9 out of 10 patients with this type of neuropathy, along with numbness, tingling, pins and needle sensations, and in some cases sharp electric shock-like feelings. So when burning feet appear together with dizziness on standing, unusual sweating, or a racing heart when you change position, that is not for random complaints. Research suggests that pattern points toward one shared small fiber and autonomic nerve problem, not four separate mysteries. It's also worth knowing that this kind of neuropathy has sometimes been found in patients whose diagnosis took years to arrive, with an average gap of several years between when symptoms started and when small fiber neuropathy was formally identified, largely because it doesn't announce itself the way a classic nerve problem does. Consider a second composite example, again built from commonly reported patterns rather than a single real patient. A woman in her 60s with Sjogren starts noticing her feet burn most nights, but only some nights, which makes it hard to describe to anyone. She also feels lightheaded when she gets up too quickly, something she chalked up to low blood pressure or simply standing up too fast. A standard nerve conduction study comes back normal, and for a while that closes the conversation. It's only when she mentions the burning feet and the standing up dizziness together, on the same visit, framed as one pattern instead of two separate complaints, that a skin biopsy is finally considered, and it shows the small fiber changes the earlier test could not detect. This kind of scenario illustrates why a normal result on one type of test does not mean every type of test has been tried. The medically responsible action is specific. Track when the burning sensation happens, whether it's worse at night, and whether it comes with dizziness when you stand. Note whether standard nerve testing was ever done, and if it was normal, ask your doctor directly whether a skin biopsy for small fiber neuropathy or autonomic testing would be appropriate, since standard testing alone may not capture this. This is not a symptom to just live with quietly. It is also, importantly, distinct from an emergency. Recurring dizziness on standing is worth discussing with your doctor. But sudden fainting, chest pain, sudden severe weakness on one side of the body, slurred speech, or sudden vision loss are established warning signs of a possible medical emergency and require immediate care, not a scheduled appointment. This nerve pattern also helps explain something almost every Sjogren patient has been told at some point, that their exhaustion and their fog are just something else. Think about the moment you're mid-sentence in a conversation, and the word you need simply isn't there. Or you read the same paragraph 3 times and still can't hold on to it. Or you leave the stove on because your mind was somewhere else entirely, and it frightens you a little when you notice. This experience has a name patients use constantly: brain fog. And here is something that deserves to be said plainly, because so many Sjogren patients have been told their fog and fatigue are simply depression, or simply stress, or simply fibromyalgia, as if naming it that way settles the question. A systematic review of Sjogren-related cognitive symptoms found that brain fog and mild cognitive difficulties were reported in roughly 40 to 80% of patients across different studies, depending on how it was measured. A more recent 2026 narrative review, drawing on research through mid-2025, found that reduced quality of life in Sjogren disease was driven largely by fatigue and emotional burden, not primarily by the standard blood tests doctors use to measure disease activity. That distinction matters enormously. It means a normal blood panel does not mean a normal day. Some research has also looked at antibodies against a specific brain receptor, called the NR2 subtype of the NMDA receptor, finding a correlation between these antibodies, cognitive difficulty, depression, and even measurable differences in a brain region involved in memory. This research is still developing, and it does not prove that every case of brain fog has this exact mechanism. But it offers a biologically plausible explanation for something patients have described for years without a clear answer. Here is why this belongs in a video about overlap syndrome specifically. Brain fog in Sjogren is frequently described using the same language as fibromyalgia's fibrofog, and doctors are advised to screen Sjogren patients with cognitive symptoms for depression, fatigue, thyroid problems, and fibromyalgia together, because these conditions overlap and influence each other. That means your cognitive symptoms may be shaped by more than one process at once: nerve involvement, inflammation, sleep disruption, thyroid function, and mood, all layered together. That is not the same as saying it's all in your head, and it's not the same as saying medication alone will fix it. The responsible action here is to track when brain fog is worse, whether it follows a bad sleep night, a flare of joint or nerve symptoms, or a stretch of high stress, and bring that pattern to your doctor along with a request to check thyroid function specifically, since thyroid disease frequently overlaps with Sjogren and is a treatable contributor that's easy to test for. That thyroid connection deserves its own moment, because it's the most common overlap of all, and it's also one of the easiest to test for and treat. Research consistently finds that autoimmune thyroid disease, including Hashimoto's thyroiditis, overlaps with Sjogren disease more often than almost any other condition, with some studies placing it around 1 in 5 patients, and subclinical hyperthyroidism, a milder form that doesn't always cause obvious symptoms, appearing in roughly half of those with thyroid overlap. Picture this. You are already exhausted from Sjogren. You are already foggy. And an underactive thyroid can deepen every one of those symptoms further. More fatigue, more brain fog, more feeling cold, more constipation, more difficulty losing weight no matter what you try. Because thyroid symptoms and Sjogren symptoms overlap so heavily, an undertreated thyroid problem can hide inside what looks like just Sjogren being Sjogren. The good news here is genuinely good news. Thyroid function is one of the simplest, most standardized blood tests in medicine, and if it's off, it is very treatable. If your fatigue, fog, or temperature sensitivity has gotten worse, or if you've never had a full thyroid panel including thyroid antibodies, that's a low-effort, high-value question to bring to your next appointment. It's worth noting that subclinical hyperthyroidism, by definition, doesn't always produce the textbook signs people expect, like obvious weight gain or a visibly swollen thyroid. Some people with subclinical thyroid dysfunction feel almost nothing different day to day, while others feel every bit of it laid on top of their Sjogren fatigue. That variability is exactly why testing, rather than guessing from symptoms alone, is the more reliable path here. Now let's step back and connect all of this, because the pattern across every overlap we've covered is the same pattern, showing up in a different organ each time. Sjogren disease alone is often already underrecognized. But Sjogren combined with another autoimmune disease behaves like its own condition, not a simple sum of two checklists. With lupus, it may carry its own distinct clinical identity, deserving its own attention rather than being treated as an afterthought. With rheumatoid arthritis, it can measurably resist treatment response, showing up as a plateau your doctor may misread as your eye medication simply not working well enough. With scleroderma, it can raise the stakes on your lungs and compound your swallowing difficulty through two separate mechanisms at once, in ways that reward early attention. In your nerves, it can hide behind a normal nerve conduction test while a skin biopsy tells a different story, connecting burning feet, dizziness, and an unpredictable heartbeat to one shared small fiber problem. And in your mind, it can produce a fog and exhaustion that standard blood tests were never built to measure, often unfairly relabeled as depression, stress, or just getting older. None of this means every symptom you feel comes from an overlap. It means one symptom rarely tells the whole story, and timing, clustering, and progression give your doctor something a single complaint never can. Your symptoms are real even when the cause isn't obvious yet. A normal test does not make your experience imaginary, and needing more time to finish ordinary tasks, more bites of water at dinner, or a slower morning routine to work around stiff joints, is not a personal failing. You deserve a medical evaluation that looks at the full pattern, not just one piece of it at a time. It's worth saying directly what this is not. This is not a claim that every autoimmune patient secretly has 5 hidden diagnoses waiting to be found. Most days, most symptoms, have an ordinary explanation, and chasing every ache as evidence of a new overlap would create its own kind of exhausting uncertainty. The goal here is narrower and more useful than that. It's simply this: when a cluster of symptoms keeps showing up together, again and again, in a way that doesn't match what one diagnosis alone would predict, that cluster deserves a specific conversation, not a shrug. You are allowed to bring a written pattern to your appointment. You are allowed to ask a specific question instead of a vague one. And you are allowed to ask for a test that looks beyond the standard panel, especially when your lived experience and your lab results don't seem to agree with each other. If any part of what you just heard felt like it was finally describing your life accurately, that recognition matters. Some viewers type "me too" at this point, and if that's true for you, you're welcome to as well. Before we close, here is a 5-question pattern check you can use before your next appointment, not as a diagnosis, but as a way to organize what you already know about your own body. 1. Do your fatigue and joint pain flare together, or independently? 2. Does dizziness on standing happen with burning or tingling in your feet? 3. Has your treatment plateaued despite medication adjustments? 4. Has anyone ever checked your thyroid antibodies specifically, not just basic thyroid levels? 5. Has anyone ever discussed small fiber neuropathy testing, like a skin biopsy, as separate from a standard nerve conduction study, or asked about your swallowing pattern separately from your dryness symptoms. Bringing written answers to these 5 questions gives your rheumatologist something concrete to work from, rather than a list of complaints that feel disconnected. Here is your final pattern to carry forward. What you learned today is that in Sjogren overlap syndromes, the worst symptom is rarely the most obvious one. It's the one hiding in the space between 2 diagnoses, the one that shows up as treatment resistance, a lung or swallowing finding, a normal-looking nerve test, or a fog that gets blamed on your mood. What to document? When symptoms cluster together, not just their presence alone, including timing between joint pain, skin changes, dizziness, burning sensations, swallowing difficulty, and fog. What deserves a routine medical conversation? Treatment plateaus, persistent fatigue that doesn't match your labs, new swallowing changes, or nerve symptoms after a normal nerve conduction study. What requires urgent attention? Sudden severe breathlessness, choking that does not resolve, chest pain, fainting, sudden one-sided weakness, slurred speech, or sudden vision loss, all of which need emergency care immediately, not a scheduled visit. What uncertainty remains? Researchers are still working out exactly how much of brain fog, fatigue, and pain in these overlaps comes from nerve involvement versus inflammation versus other shared mechanisms, and that research is actively evolving. One question is still sitting there, unanswered, and it's the one we'll go after next. If small fiber neuropathy can hide behind a normal nerve conduction test, what other Sjogren complications are being missed by tests that were simply never built to look for them? That's where we are headed in the next video.